السلام
دكتور
عليكم.
سعد. السلام عليكم دكتور سعد،
وعليكم السلام، حياك الله دكتور عواد.
كيف حالك؟
دكتور وليد ميت، اهلا وسهلا فيك، حياك الله،
اهلا
يسعد
وسهلا
مساك.
بكم، كيف اموركم؟ طيبون ان شاء الله؟
بخير الحمد لله، كيفك انت؟ طمنا عنك.
والله الحمد لله تمام، ابشرك طيبون ولا الحمد.
الحمد لله، الله يديم عليك الصحة والعافية يا رب.
وياكم جميع الاحباب، الله يسعدك.
حياك الله، احنا waiting للاذرز تو جوين، يعني معنا حوالي 10 دقائق.
ممتاز. خلينا نحط هذه السلايدز ولا
يلا
نطلعها؟
شير سكرين.
طيب يلا. ايوه، سو شير سكرين، بعد ذلك هذه شير، بعد ذلك بنسوي هذه.
بدعت.
طيب وهلا هذول بيسكروا الطريق ولا ايش هون؟
لا انا بالنسبة لي لا.
طيب ما حتكون مضرة هذه لهلا. نشوف، هذه احنا شغالين على واحد منهم، هذه ما لها قيمة على الناحية الثانية، هذه مهمة هون. الجانب هذا كيف ممكن هلا مأثر عليك بالرؤية؟
لا انا بالنسبة لي لا، انا حاط الفيو تبعي بحيث انه بعيد عن السلايدات.
طيب اوكي، فير انف، ولا حد حيتأثر فيهم.
لا باذن الله رب العالمين.
جميل جميل. كيف الدنيا عندكم؟
والله عندنا رجعت برد شتوية من اول وجديد.
والله هو الامور براد يعني صراحة. الى الاسبوع الماضي وعندنا الصبح بيكون براد على غير عادة، شكله عشان ما في سيارات في الشارع.
ممكن
تأثير الموضوع. هلا جماعة الجلوبال وورمنج مهيصين انه كل المصانع وقفت وكل الدنيا وقفت.
والله هو بدك صراحة زي ما مرة كتبوها انه يعني it's getting better with time.
دكتور سعد. Oh, I don't hear you دكتور سعد. دكتور سعد, you are muted, I guess.
Can you hear me?
Yeah, now I can.
Yes. Friends, we welcome you all with this scientific webinar. This is a joint meeting between Jordan, Saudi Arabia, Egypt, Iraq, Pakistan, and Gulf area. We thank all our participants. We thank all those who contributed to the cooperation with each other. And we would like to continue this movement in the next few weeks, even if the lockdown is going down. We'd like to continue with this participation. You are at your home, you're at your ease, you can listen, you can share your opinion, and you can ask the questions and ask the experts, and hopefully we'll continue in this manner in the next few months also. We would like to welcome our guest. He's Dr. Walid Awad. He is an associate professor and consultant of spine and scoliosis surgeon. In 2003, graduated from College of Medicine King Saud University from Saudi Arabia. In 2010, Canadian Orthopedic Board from McGill, Canada. And 2012, Orthopedic Spine and Scoliosis Fellowship from McGill, Montreal, Canada. And he is the chairman of AO Spine Saudi Arabia, and he's working at King Saud University in Riyadh. Welcome, Dr. Walid, and hope we will benefit a lot from your lecture.
Thank you very much, Dr. Saad. Actually, it's my great pleasure to be with you. Today, we planned this for a while, but I guess Corona make it easy to happen, faster and easier. So actually, sacroiliac joint, it's a kind of complex joint, and it's not infrequent to see such a patient, which is a 48-year-old female patient, multi-gravida, multi-bara, presented with right-sided leg pain down to the foot, and presented with this MRI with this complaint, and said everyone told her that she had this mild disc which is not explaining her symptoms. She tried physiotherapy and pain management, and no one was able to help her out. So classically, if you think that this patient would have sciatica, it should be left-sided due to the annular tear. And then if sacroiliac joint with overlooked or other pathology will be overlooked, then patient will be misdiagnosed. As we know, it's not only sacroiliac joint that can lead to, the disc or sacroiliac joint can lead to leg pain, multiple other pathologies. We're going to go through it through our lecture, which will mimic sciatica and sciatica type of pain. If we look here for the same patient CT scan, we can look and find clearly vacuum phenomena, sclerosis, and some osteophytation for both sacroiliac joint, and we'll go through this later on. So generally speaking, we are talking about sacroiliac joint. As we know, it's one of the largest or the largest axial joint in the body. As well known, it's capable of producing pain, and it is poorly defined in the literature. If we are talking about general epidemiology, sacroiliac joint, it's commonly cause axial lower back pain, affecting 10 to 25% of the population. And the pelvis itself can produce pain and referred pain to extremity up to 6 to 13% as a source of lower back pain and referred pain. Why it is least understood? Because it's complex joint. It is a diarthroidal joint, mainly for two areas of the joint, which is the inferior, which is synovial, and the superior, which is fibrocartilaginous. And two surfaces with the sacrum and ilium, which is different from each another. What I want to make your attention to is that there is numerous ridge and depression in the sacroiliac joint, and its function as stability more than motion, as I defined in multiple literature. If we're talking about ligamentous structure around the sacroiliac joint, we can see that posterior, the ligamentous complex is really rich and really complex compared to the anterior sacroiliac joint and ligamentous structure. So we know that the posterior is main stabilizer of the sacroiliac joint compared to the anterior. There is multiple other joint in adjacent to the sacroiliac joint itself, with the iliolumbar ligament, as well as the sacrotuberous and sacrospinous ligament, were both again associated with similar pain pattern. If we're talking about the ligaments around the sacroiliac joint, it's very high in high threshold group 3 nociceptors. So those ligaments capable of producing and receiving pain. So it is fully innervated with group 3 nociceptors in the ligament itself. If we are talking now about the sacroiliac adjacent structure, as we said, in the 6 to 13% in pelvis region can refer to leg and lower limb mimicking sciatica. So if we're talking about the sacrotuberous ligament, it's producing pain from mid buttock all the way down to S1, similar to sciatica, S1 sciatica, more profound than sacrospinous, which is less profound. And most of the literature will not reach the foot, but it's less profound and not intense at the sacrotuberous ligament. Now, if we are talking about another ligament around this area, in the pelvic area, is the iliolumbar ligament, which is sometimes commonly injured during surgery to achieve fusion, or you can happen due to strain and other. It's causing lower back pain and mainly diffuse inguinal area pain in the medial thigh as well. So in male, classically in the literature, found patient complaining of scrotal pain down to the testicle, or he will describe it classically as something crushing his testicle. Most of the time he would see urologist first, then there will be no pathology, and this could be really missed. And the management, most of the time, if you do local injection to the iliolumbar ligament, this will relieve the patient symptoms. Then you can try to achieve, try another modality. And this is easily done at the clinic, the local injection for iliolumbar ligament. As we know, the pelvis, again, there is multiple muscle has an action on the pelvis and pelvic area and the sacrum. as we know it. The most important muscular group, which is multifidus, latissimus dorsi, gluteus max, biceps, and the piriformis. A function for erector spinatus flexion and extension of the pelvis, as well as the sacrum, as well as nutation and counter nutation. We're going to talk about it, which is sacroiliac joint function. Now, if we're talking about the muscular pain and distribution, again, quadratus muscle will produce buttock pain as well as inguinal pain and anterior hip pain, which is classically will be mistaken as hip pain, and the center of the pain will be in this starred area, which is patient will benefit from physiotherapy and some chiropractor practice. If we're talking about the piriformis, biceps femoris, the pain will be in the posterior thigh, as well as it could be the ischial tuberosity type of pain or related area, which will be significantly in the buttock and down to the knee. It will not go beyond the knee. I saw this frequently after spine surgery or revision spine surgeries, and patient will benefit from local infiltration. Piriformis, it's really classic, causing sciatica type of pain because piriformis and the sciatic nerve in close proximity. It could be seen in MRI, especially inflamed or thickened. Physiotherapy, stretching, then injection, very rarely release for the piriformis due to persistent pain. Now, if we're talking about the innervation, we know that the innervation goes from L4 medial and 5 and all the way to S1. It goes through literature and multiple history, but this is the innervation. It's in close proximity of anterior lumbosacral plexus, posterior medial branch of L4, L5, and lateral branches of S1 and S4. That's why if anyone would consider doing the final treatment or semi-final treatment, which is radio frequency ablation, should include the L4, L5, L5, S1 facet, as well as those lateral branches in the sacral foraminals. Now, for the range of motion, which is nutation and counter nutation, if we're talking about nutation, which is the sacral locking, where it's sliding inferior posterior, where the ilium approximate and the ischium diverge, as increasing the outlet and decreasing the inlet. So the could happen bilaterally or unilaterally. Unilaterally, the locking with hip flexion or extreme hip flexion. Just keep this in mind. It's locking with extreme hip flexion. I'm going to talk about it in a minute. Counter nutation, where the widening of the ilium and approximating of the ischium could again happen with bilateral or unilateral, which is the opposite of nutation, which is sacral unlocking. Generally speaking, as we age, the sacroiliac joint decrease in range of motion till the age of 80, which is almost immobile sacroiliac joint. Sacroiliac joint initially get popularity by the gynecologist, then orthopeds get more interested with this joint. And then now there is frequently pregnancy-related pelvic pain causes. Funny, just as per history, for cephalic pelvic disproportion, when the pelvis will not accommodate the fetal head, they will do open book pelvic fracture to get the fetus pass, where the mother most of the time would die while the fetus will survive. And this is as part of the history. You can ignore this generally speaking. Now, multiple times there will be altered in the diaphragm and other adjacent muscle function with straight leg raise due to sacroiliac joint. Bilateral compression of the sacroiliac joint, where stabilizing the sacroiliac joint, this kinematic will back to normalize, where loading it will normalize the function around this particular study. General, there is multiple axis of range of motion around the sacroiliac joint in y-axis, x-axis, and z-axis, but almost all, if we are talking generally speaking, it's around 2 to 4 degrees. It's not a huge range of motion, and it's there's no common axis in both pattern. If we're talking now about the pain pattern, again, we're talking about muscular pain pattern distribution. In A, we can see the quadratus lumborum again, so it goes even flank pain. So this is, again, remind myself always whenever a patient complaining of flank pain, they saw urologist and they saw internist, and it's not the source of the pain. Again, consider quadratus lumborum. The trial of physiotherapy and chiro might help if this spine is not a major source, as we know, because to get quadratus or this area of flank pain, always we think about thoracic spine. If thoracic spine examination is clear, then consider quadratus muscle as a source of the pain. Piriformis, again, goes down as sciatica type of pain. We saw the iliopsoas could go in the inguinal area, but does not reach the scrotum or the medial thigh. Rotator and multifidus goes again abdominal or anterior pain. For the ligaments, again, just to recall this, iliolumbar ligament goes down to the medial thigh and to the scrotal area, while the sacrospinous sacrotuberous mainly leg compared to the lower back, while the sacroiliac joint back diffusely and goes down the leg and as if it's S1 distribution. So the most important thing is we should consider differential diagnosis of the referred leg pain, which could be related to muscular area, ligamentous area, sacroiliac joint, or spine. And it is really complex and difficult to be specific and sensitive fully about the sacroiliac joint itself or even adjacent structure. For example, if they took this cut, we're looking at the synovial part of the sacroiliac joint and the fibroculturales part. And if you are loading the sacroiliac joint here at this area, you will be still loading the facet and you're still loading the iliolumbar ligament. So there is multiple chance that you will get false negative or false positive results because you are loading adjacent structure, which is important adjacent structure as well. Now, as you know, there is multiple specialties and profession taking care of the leg pain and lower back pain. If we say, generally speaking, general practitioners start to deal with this patient, you will start with neuropathic killers. If patient with radiculopathy or sciatica or leg pain down the leg, we'll start with nerve conduction studies and so on. Similarly, if God gives you a lemon, you will make a lemonade. So that's what's the tool in his hand so that he will use. But there, and some of the time, it's different approach between surgeon and physician, but we'll talk about this as we go. But what is the really important here? That we should be taking thorough history, as I mentioned. So thorough history is extremely important, not overlooking the other source of referred pain, goes down to legs or others. Again, you must include red flags. It's not uncommon that there will be sacroiliac joint infection, especially in brucella or another, or there will be another infectious or tumor pathology at this area or adjacent area, especially in the hip joint, for example, or the sacrum. Pain, generally speaking, if the pain or the maximum intensity of the pain below the L5, which is below the iliac wings, it will be most likely below the L5, which is the 410 site for the examination. Generally speaking, as I said, for examination, you should examine the patient fully, gait, leg length discrepancy for hip pathology and other obvious deformity, Trendelenburg 410 test, straight leg raise test, full neurological examination, again for knee and hip to rule out referred pain. If we are talking about the 410 finger test, it will be below the L5, so those iliac crests. So if it's below, and this area of patient, which is finger test, you will ask the patient, show me the maximum intensity of the pain. If you will put one finger to that area, then it is the most likely the cause of the pain. For the sacroiliac joint pain, again, it's patient sometimes will be leaning from side to side. So he will to offload the affected area. So if the area is only unilateral, he will try to sit on the other to offload the sacroiliac joint. If it's bilaterally, they will classically tell you that I'm leaning from side to side. Another pain, classic pain, as he will say, sitting on a spike. So if he said, I'm sitting on the spike in the buttock, not in the natal cleft area, which is the coccyx, so in the mid buttock, as if he's sitting on the spike, it goes with sacroiliac. Pain with changing position, start of changing position or going into the stairs. And sometimes they'll tell you I'm holding the area to stabilize, but I didn't hear my patient saying that, but this is in this 14 paper, which is one of the most important papers. For provocative test, there's no really single test, as we said, because its area is rich. There is L5, S1 facet, there is the iliolumbar, there is multiple muscle areas, so there are multiple high chance for false positive or negative. That's why we try to do more than one test. So if there is 3 tests or more positive, then it could reach up to 93% probability of sacroiliac joint pain pattern. If it's less than 3, it's up to 72 that the sacroiliac joint is not the source of the pain. Again, now we know that there is one historic test, which is the standing, single leg standing and hip flexion test. And this test is now obsolete. It's not one of those provocative tests because the hip flexion will lock the joint and will eliminate the pain. And as we saw in 2000, it's not a good joint. But the other joint that it will be used, which commonly, the first 4 actually more commonly used than the other, I'll say as we go. So the Patrick test was the flexion, abduction, external rotation test. Then we're talking about the gapping test, where you're trying to exert the gapping or open pelvis maneuver on the sacroiliac joint. Then compression test, thigh thrust test, then Gunnarsson or pelvic torsion test. And here I just want to draw your attention. Look how differently those tests are applied, how much flexion of the hip and extension of the others, while this is done in lousy or semi-lousy way, and this is in aggressive way. So that way, again, there is different in the sensitivity and specificity at the test, because it could be done in proper way or according to the body habitus of the patient and the examiner himself. Sacral thrust, most of the time not done because you need to change the position of the patient. It's uncomfortable to change the patient position in the clinic most of the time. That's why the others will be commonly used. So now, as we said, so if you get more than 3, you can reach up to 93% that the sacroiliac joint is the source of the pain. But if it's less than 3, sacroiliac joint is less likely to be. More than 72, that's the source of the pain. As we said, there is a high false positive result because difficult to distinguish intra or extra and the adjacent facet joint. Most of the physician, they will use the test to rule out sacroiliac joint dysfunction rather than rule in sacroiliac joint dysfunction. So if you get to think about the sacroiliac joint as the source of the pain, as well as you got some positive tests, so then we can augment with radiological images. X-ray, as with simple X-ray in advance, you can find the positive sclerosis. But CT scan will be more sensitive and specific, although it will not reach more than around 70 or 60% sensitivity and 70 in specificity. But we can see the cyst formation, as we said, vacuum phenomena, sclerosis, and osteophyte. We'll see some examples. MRI, it's really good for early inflammation and edema, especially early infection as well. As we can see here, you can see significant edema. Bone scan, it's coming to be less unused, but it's highly specific but not sensitive, and it is good for inflammatory conditions. Now, another way to diagnose the sacroiliac joint or reach the diagnosis is the diagnostic/therapeutic block. If you are aiming for a block, you will aim for the inferior, which is the synovial part of the joint. And usually the capacity of the joint will accommodate up to 1 cc, but it's vary, some between 0.5 up to maximum reported up to around 2.5 cc. The average is 1 cc. You will get more diagnostic properties and confirmation if you use the radio-opaque dye. So, and there's another study done. If you do the sacroiliac joint block blindly at the clinic, you could reach the joint in less than 50%. And if you do it without the dye, you only ended in the joint itself in around 20, maximum 25% in the sacroiliac joint. So what about single block or double block? If you give one block and there is bare relief more than 75% to 100, this is suggestive, especially if it's two block. Fair if it's around 50 to 75. Now, general algorithm for patient once compiled for lower back pain and referred pain, as we said, you'll take history, you rule out red flags, then you will do full evaluation, as we said, for everything, for lower back, gait, hip, leg length, and neurological examination. If any of those positive, then you are talking about hip pathology or lumbar spine pathology because you are doing neurological. But if all negative, then you should consider sacroiliac joint. Then you will do investigation, including x-rays and adjacent images as needed. You'll start with, as usual, conservative management. If there is no pain relief, then you will do the diagnostic injection. You can do it twice. If it's positive once, you can go for the definitive management. Or if it's negative initially, you can repeat it. If it's positive, you'll go to definitive treatment. If it's all negative, then we'll investigate for another cause other than sacroiliac joint and spine related, because there is extra articular or extra spinal causes. Again, it should be ruled out. The pain management or the intervention pain management, they are different. So they will consider sacroiliac joint pathology, they will rule out red flags, then they will do immediately diagnostic injection. If it's positive, they will consider the radiofrequency ablation, as we said, from at least L5 to S1 REMI. If it's negative, they reconsider the diagnosis. General take-home messages for this condition: it's challenging. It's capable of producing pain down the leg. It's provocative tests are better for ruling out rather than ruling in, but if used and combined, it will help ruling in. Images, as we talk about it, then use diagnostic versus therapeutic block, and then follow the algorithm. But as I'll tell you, every one of us has his own algorithm, as long as we are thoroughly examining the patient, including sacroiliac joint initially for any lower back pain, piriformis, and general examination pattern. It's unlikely to miss it, but just keep it in the back of your mind. Now I would like to go through a few cases just to highlight those significance. So this patient referred with right-sided leg pain, goes down the leg. She got this surgery done at another hospital. It seemed to be now solidly fused, although there was some halos around the screws, but the CT scan showed that probably those were initially, then it's fused. But clearly here we can see obvious sacroiliac joint in the right side. There is vacuum phenomena. It's considerably open more than the other, and there is osteophyte even goes on the back. It's not only images, as we said, because initial images as well as examination was not consistent with patient to have discopathology or something required revision. Sacroiliac joint was under concern, and diagnostic block relieve the patient symptomatology. Then patient sent for radiofrequency ablation for confirmative management. This is our patient, which is the 48 years old female, multipara, with this recurrent right leg pain, significant sciatica type of pain, but negative straight leg raise, normal examination. And this we cannot explain the patient's symptomatology. All those patients even received the epidural, and she did not help her at all. Examining sacroiliac joint for her was really positive. You can see the vacuum phenomena. We can see the osteophytation bilaterally, although we can see some facet joint osteoarthritis, but this will not explain the pain goes down the leg. Could explain back pain, but not leg pain. And then diagnostic block, sacroiliac joint block helped the patient significantly, and she was pleased. There is another, again, patient with classic, even X-ray feature of sclerosis, some widening of the sacroiliac joint, although there is significant osteophytation, L4-5. If we see the CT scan, there's significant sclerosis, vacuum phenomena, decreased joint surface, and irregularity. Even in fluoroscopy, we can see the sclerosis. Bilateral initial block was positive, then radiofrequency ablation by our pain management colleague. Now, what about if you got those positive results and you want to do the definitive management, or the sacroiliac joint radiofrequency ablation did not give the patient proper relief due to significant dysfunction? Then we can go through the minimally surgical option, which is the minimally invasive fusion of the sacroiliac joint using the tantalum block. So the way this would be done, we need, as we know, whenever we are talking about MIS surgery, we need perfect imaging. So we need perfect true lateral, where we can see the sacral promontory and the real pelvic brim. Then we need inlet view and outlet view. So this is the outlet and the inlet view for the anterior, posterior, as well as here for the foraminal view. Once this identified, we put a line, because this is, again, because this is the sacroiliac joint and this is the promontory. There is no joint here, so we need this line as we saw it in previous image, which is this line. And then one line on the posterior sacrum, then we'll go 1 centimeter and mark 3 centimeter distally. This will be the skin incision, blunt dissection till you reach the bone. Then you will start our, as we said, images to make sure our guide pin will be, and to avoid the anterior centimeter of the sacrum. And again, we don't want to be really here in posterior canal or anterior to cut anteriorly. And we should be first pin or first tantalum block above the S1 foraminum. Once this advanced, you can the drill over the guide wire. Always pay attention that you are not re-advancing the guide wire. Then there will be a protective sleeve, and this should be parallel to your alar wall line initially, and the flat surface with the flat surface of the sacrum, avoiding the canal. So it's parallel to the canal here and parallel to this line. You should not be anterior, you should not be posterior. Then first tantalum block will be inserted, then there will be another guide, a preset guide, where you will put it distal to the first one and shy to the foramina. Most of the time, it's easy to put 2 tantalum block. The recommendation is 2, preferred 3. So sometimes you cannot put 3, but that's fair enough. But you cannot put only 1. So minimum 2, preferred 3. After that, you'll be closure in layers, and then 3 weeks partial weight bearing, and then gradual increase the weight bearing to full weight bearing after that immediately. And you can confirm by CT using software to minimize the scattered. You cannot do both sacroiliac joint at the same sitting, because patient cannot be partial weight bearing and bilateral lower limb. So at least 6 weeks apart for both sacroiliac joint. So that was the overall my humble lecture about the sacroiliac joint and pelvic referred pain due to adjacent structure. I would like to really again to thank Dr. Saad Hamdan giving me the chance to present this talk. And I'm really open for to share knowledge and information and discussion with you regarding this topic.
Thank you very much, Dr. Walid. This was an excellent review of the sacroiliac joint, and we have actually a question from Dr. Atiq Zaman. I'll put him on a speaker.
Yes.
Dr. Atiq, mute yourself and you can ask. Dr. Atiq, mute yourself. Yes.
Can you hear me now? Yeah.
Yes, we can hear you now. Welcome, Dr.
Assalamu
Atiq.
alaikum. How are you?
Alaikum assalam wa rahmatullah.
Walid, in our practice, when we have doubt about the SI joint, we usually go for the bone scan. And if it came out to be hot, then we can focus on finding the any cause. Because usually in our practice, if it is a persistent pain in the SI joint, it came out to be infection, and we have to go for the biopsy and the fusion, like you have told. What's your experience with the bone scan?
Yeah, so that's a good you mentioned, because there is, I believe, maybe a lot of brucellosis or maybe even TB-related infection at your area. So the bone scan is really good tool. The thing is, for my practice at the now Saudi, which is now 8 years, I saw only 2 infections of sacroiliac joint to be related to brucellosis or another infection. So it's not that common, like only 2 patients in both private and the governmental section, where both patient actually was in governmental, I mean in the private sector rather than in the governmental section. Most of the pain-related sacroiliac joint will be dysfunction related to multiparity at Saudi. I'm not sure if it's different pattern at your country, but most of them will have multiparity, like 8, 10 kids or 11 even, and they will have bilateral sacroiliac related changes and dysfunction. But even the infection itself easily could be seen by the MRI. So MRI is really good with detecting infection itself, initially by edema, or especially if you are in doubt, it could be with gadolinium. I believe that bone scan would be more practical and cheap, could be, but rarely I need to do nowadays the bone scan. Most of the time, X-ray, MRI, and CT scans. But it's really valid option. It's not uncommon to be used.
Thank you, Dr.
May I comment? May I comment, Saad?
Yes,
yeah,
please.
Walid, excellent talk, really. I learned it from it. I learned it from it. But I like to comment about and highlight something from the history. If this patient complaining from sacroiliitis due to encephalopathy or something like ankylosing spondylitis, the pain will come mostly in the morning. It will be associated by some symptoms like morning stiffness or something like in other facets. If it is a degenerative sacroiliac joint pain, it will become by, as you told, by loading the sacroiliac joint, like sitting on a chair or something like this. So from the history, you can reach your diagnosis. Also, the presence of infection, I'm completely agree with you. In our area, it is during my career, I saw only 1 case with infection in sacroiliac joint. Unlike Pakistan, Atiq has a series of infection in sacroiliac joint, which is very interesting. And I believe, as you said, MRI will be much easier and safer even than the doing bone scan for these cases.
Yeah, thank you very much for your comment, Prof. Muhammad. I fully agree with you. Actually, I didn't go through the seronegative arthritis and ankylosing spondylitis, but I fully agree with you. Their pain pattern will be different, but again, it will be buttock type of pain, early morning stiffness, and others. Sacroiliac joint loading will be positive for them. Mainly, MRI will show the edema, most of their management will be related to, especially initially, as long as there is no sacroiliac joint dysfunction, biologic agent and by rheumatologist, rarely they will need initially or immediate even block versus radiofrequency ablation. The rheumatological management, especially if they caught early, the pain will be relieved. Is that the same you experienced in your practice, Prof. Muhammad?
Yes, yes,
Yeah.
completely agree. Completely agree with you. Completely agree.
Thank you, Prof. Muhammad.
You know, I'd like to highlight also one of the most common causes of sacroiliac joint pain, that after lumbosacral fusion, L5S1
Yep.
or even L4-5.
Absolutely.
And I found in my practice that it is most commonly anticipated in females. It is more common in short stature. It is more common in diabetics. This is my thoughts about post-operative sacroiliac joint pain. Females, short stature, diabetics usually complain from sacroiliac joint pain post-operatively. This is something attracted my vision during practice. And I used to inject them, and they really improve by single or twice injections. Do you have the same experience, or there is something different from that?
No, actually the same, especially like, as I said, multiparity as well, because it's the similar generation. The older patients, they are multipara, so they have the same. Actually, sometimes but I stopped kind of doing that. At one point, I was cheating. Whenever I'm doing the lumbosacral fusion, especially in females, actually only in females, I would inject the sacroiliac joint all the time. They will be very happy, then they will get the pain. But for me, because I would know initially, I was worried about the sacroiliac joint, so I would know that this pain would come back. Now it's sacroiliac. I did inject it after the surgery. They were extremely happy now. The pain recur. I'll send them to radiofrequency, but I stopped doing that because it's the pain management. They were not happy about this, but patient was happy.
Okay, great.
Patient will be extremely happy after surgery.
This is our aim.
Yeah. Dr. Saad, you are muted. You are muted. Unmute yourself, please.
Hello.
Yeah, تفضل.
Yes. Dr. Muzahim has a question from Iraq. Dr. Muzahim, unmute yourself. Yes, please, Muzahim.
Hello, Saad. Assalamu alaikum. Many thanks, Saad, and many thanks to Walid for this very common topic, but actually underestimated pathology in our daily practice. Thank you, Walid. Walid, I have three questions.
تفضل.
The first one, what's your experience about radio frequency? How it lasts? I mean, we have a very short experience with cases treated by radio frequency, but actually it did not last more than 6 months or 1 year, and then the symptoms recur. The second question, do you have a long-term follow-up, or do you review a long-term follow-up on cases treated by fusion in regards to prognosis? And the third question, what's your tips how to avoid this pathology after lumbosacral fusion?
Yeah, okay. So for the first question, actually, you got the answer by within your question. It's really lasted up to 1 year. Although the pain management, they will claim it could be permanent or give the permanent results, but usually I found it last, the maximum is 1 year. I got few patients sent initially, they got the recurrent pain after 1 year, where they got to repeat radiofrequency ablation. They said if it's gonna be done every 1 year, then fair enough. There, as you know, most of the patients, they are afraid from doing the surgery. So this was the first question. The second question was again, remind me, Dr. Saad. It was
again the prognosis of the fusion for cases treated by fusion.
So the fusion, fusion actually, it's really, as you know, whenever you are using tantalum plugs, most of the time, if you put it immediately, you cannot get it out because it's really difficult to get out. So most of them, they will fuse, or at least they will decrease the pain pattern. It has to be at least 2 plugs. 1 plug, which will not be enough to get the joint itself fused and to eliminate the pain. Most of the patients, they are satisfied. They got some, at least good to excellent relief. Regarding the last one, how to avoid, actually sometimes it's difficult because, you know, whenever you are fusing one joint, you are loading the other joint. As we know in orthopedics, if you are fusing the ankle joint, it's forefoot or midfoot arthritis and vice versa. It's not uncommon actually to see this. There was a study, the spinal hip or hip spine pathology. Whenever you fuse the spine, there will be the hip joint will be arthritic, and the vice versa. It's one paper is published. So you will see patient with total hips. After total hips, they got to have the tantalum plug or sacroiliac joint fusion to the sacroiliac joint, or most of them they will get spine-related surgery and this fusion. How to avoid? Honestly, I don't have an answer unless you got through a paper and you want to share with us. That will be great.
There is two questions here, Walid. One from Dr. Muhammad Ismail.
Yeah.
What to do if patient is clinically having sacroiliac pains, but his blocking tests are negative? Do you have answer for him?
Yeah, so if you still history, you think that the patient has sacroiliac joint pathology, although, as we said, because the provocative tests are all negative still, the block is a test because we used it as diagnostic / therapeutic. So you can use the block test for sacroiliac joint, and you will rely on that as a result. If it's more than 75 to 100% relief, then this is positive. If it's less, around 50 to 70, you will be worried. As we said, if you want to be really meticulous about the block, you should use the radio opaque dye. Make sure that in the joint, and don't use more than 0.25 cc of local, because if local diffuse outside of the joint, it will give you false relief if it's diffused to the facet joint or diffused even to the L5 nerve root and adjacent. So it could give you false results. اساس كده بنقول مثلا الحنبلي only used for block diagnostic block 0.25 cc to act as diagnostic. If you go for therapeutic, you can go with infiltration nearby and again infiltrate the joint by almost up to 2.5 cc.
I think I am completely agree with you. Plus, if there is no correlation between the radiology, the history, and the block test, so this surgeon need to re-examine the patient again. Maybe he find other pathology. So there is another question. There is another question from Dr. Sam Hamid from Saudi Arabia. He asking you about how to differentiate between piriformis syndrome and sacroiliac joint pain.
Yeah, okay, sure. But then let's go this for the algorithm.
Okay,
here, as you said, if we saw in the previous, we said if it's negative, then you should re-investigate other than lower back pain related pathology. As we said, even aortic aneurysm or another causes, it should not be again ignored completely. I fully agree with you. So if it's all negative, and you should look for another reasons. Now for piriformis, there is a test for the piriformis, as I said. So piriformis, generally speaking, the piriformis doesn't cause pain at the sacroiliac joint area itself, as per the history of Fortin. It will goes down the leg. It will be goes with again loading the piriformis muscle. If you are loading the piriformis muscle, where you will do the flexion, adduction, and loading the piriformis muscle will cause the pain down the legs, while this is not loading the sacroiliac joint test itself. And finally, by MRI, as we mentioned during the lecture, if we do the MRI and we saw the piriformis thickened, or most of the time it will be more prominent compared to the other piriformis, or there will be some kind of fat stranding, will identify that it's piriformis related. And nicely about the piriformis, if patient would do stretching for the piriformis muscle stretching tests, exercises. It will relieve the pain within 6 to 3 months, especially if given muscle relaxant during the stretching exercises. If persisted, then injection, as we said, rarely ever release. I never released any piriformis muscle. I didn't get to release any. I'm not sure if you have any different in your practice, Prof. Muhammad or Dr. Saad.
During my practice, I met one patient with symptoms really, I'm completely agree at the beginning that how to diagnose the piriformis syndrome and differentiate it between sacroiliac joint and piriformis syndrome. And I used to send this patient in particular to some pain management colleagues. They can use ultrasound guided techniques to inject the piriformis itself. This is number one. So ultrasound guided local injection may help as well, and the results is usually favorable. I didn't release the piriformis during my practice, but I can remember only one case. I diagnosed him as a piriformis syndrome, and his MRI, lumbosacral spine, everything was okay. But I even injected him the piriformis. He didn't improve. So I decided to repeat the MRI, and I found new developed pathology at the MRI. So when you are in doubt, please repeat the investigations.
Absolutely.
Repeat the investigations. Sometimes some investigations are operator dependent, and that will help a lot.
Yeah, sure. Dr. Walid, we have a question from Dr. Firas Al-Hasban. Dr. Firas, please.
Dr. Walid, thank you very much for this nice lecture. That really clarifying a poor understanding joint, since it's a common misdiagnosed pathology. I would like to ask you 3 questions. The first question regarding the clinical appearance. From our experience, especially in the minimal invasive surgery and OLIF and DLIF technique, we do manipulation of the iliopsoas muscle, sorry. And usually we have some injury of the ilio muscle, so we have commonly referred pain from the iliopsoas muscle. But we have also not referred pain, we have also radicular pain, and the meaning of this, not sclerotomes, but they have dermatomal distribution due to inflammation of the lumbosacral plexus. So it can be happen also with the inflammation of the ligaments anteriorly or posterior, and we have inflammation of the roots, and we have this confused clinical appearance. This is the first question. The second question, from the history of the spine surgery, when the manufacturing, companies and the new equipments are available, there is a push of the indication of surgery. There is expansion of the indication of the surgery. So what is the absolute indication for the surgery? And the last question, sorry for my questions, that what is your approach in recurrent sacroiliitis?
Okay, so for the first one, actually, I guess it's really reported in the literature regarding the iliopsoas, because actually all the patients they will do in DLF get some radicular pain. And if you ask to any surgeon who does it, he'll tell you all of them, they will develop some paresthesia. And the issue is, as reported in the literature, it's according to who will make a complaint or who will keep complaining. As you know, some of the patients, you will do surgery, they will get out with some paresthesia, or they'll tell you, oh, thanks God, things are perfect, I'm happy. Even some of them, they will get a drop foot, and they'll tell you, oh, as long as I don't have pain, I'm happy and satisfied. Others, they will get out of the surgery, they feel some numbness comes and goes, they will cry at your clinic every day, oh, you killed me, or whatever you did, I still have pain. But for the DLIF, it's reported that all of the patients, almost all, they will get some paresthesia and radicular pain. That's why some surgeons, they don't like it as approach. Even if you are talking to Neil or others, they they done tons of those procedures, they'll tell you all the patient they will develop. You will find differently written in the literature, and sometimes they use different time frame, but all of them they develop. I don't think it's really related to the LSOS as muscular related, because this is kind of pain rather than radicular or numbness. Those patients, they don't develop numbness as it's mainly pain distribution. Regarding the second question, the industry pushing those, this is true. Whenever any industry find or developed a new technique, they will try to push. But I'll tell you, like, I was interested at the sacroiliac joint even before those industry. I didn't like the previous way of fusing the sacroiliac joint, because it's involved significant incision going down and laying a lot of bone. Even the S2 sacroiliac screw, that doesn't help to fuse the joint if you are fusing spine to pelvis. And giving all those injection, I was waiting for something new. And that once I got those tantalum plug in minimal invasive was really good, and I found really good results. So sometimes you just wait to find a good result or a good tool to use for your patient. I'll tell you my absolute indication, I don't fuse a lot. So most of the patient, I'll tell them initially, if I reach the diagnosis by any mean, and I was happy, I'll tell them it's arthritis. It's similar to knee arthritis, but this is not gonna affect your life in a way like the knees. So you can take painkiller, paracetamol over the counter, non-steroidal on and off. This is one. Second, if they repeat and reinsist, goes for radiofrequency ablation most of the time. And I did repeat, ask my colleague in pain management to repeat sacroiliac joint after 1 year, as happened as in Dr. Al-Mazahmi question. Actually, most of the time it's lasts for 1 year, not more, unless it's really transitional, as we saw sometimes epidural give will be good as one in single episode. And if fails, the repeated radiofrequency ablation, and there is significant arthritis in the sacroiliac joint versus dysfunction, meaning symphysis BOS widening, and the feature of that osteofaciation goes in the back, as we saw it in the other, or the sacroiliac joint itself, or the ilium is widened, then I'll go for the fusion. So fusion is not my first. I don't push, or I don't send my patient to fusion initially. All of them I'll send them for radiofrequency ablation first, and repeat radiofrequency ablation after 1 year. Then I will fuse. I don't fuse them all immediately, because I know that hip joint or spine will come next.
Yes, thank you very much for your answers. It's very clear, but I would like to just a comment about
go ahead, please.
The OLIF or DLIF procedure. I agree with you. A DLIF technique, it has most of the patient, 97% of the patient, they have radicular and referred pain from the iliopsoas muscle. But I can tell you that the modified technique of OLIF, that I did hundreds of cases of this technique, that just you flap don't touch, the iliopsoas muscle. Just you go with your finger, flap the muscle, and then find your entry point. And if you do the fusion within less than 20 minutes, you do all the techniques, you will not have any ischemia over the muscle. And in this technique, we don't have more radicular pain. We have some, referred pain that none of them permanent, and they will all disappear within 3 weeks. So it depends on the technique. That's why I believe that minimal invasive fusion by extreme lateral approach, if you flap the muscle and you have this modified technique, I don't have more radicular and referred pain. Thank you very much, Dr. Walid,
Thank
for
you very
this.
much. Thank you very much. Thank you for your comment.
Dr. Walid, we have a question from Dr. Muhammad Sulaiman. Please introduce yourself and ask your question, please, Dr. Muhammad.
Okay, thank you so much. My voice is clear?
Yes.
Yeah.
Thank you, Dr. Walid, for this informative lecture. Please, kindly, let me highlight some points, please. I think that the sacroiliac joint, the sacroiliac dysfunction should be considered and searched in the mind of every spine surgeon as a cause of adjacent segment disease or failed back surgery or even a low back pain. And the diagnosis is the most difficult point in this title. And unfortunately, the radiological tools are not conclusive. And the gold standard for the diagnosis for treatment is the sacroiliac injection. And there is recent researches about the injection. There is an intra-articular or extra-articular or combined one. And there is some methods to include the BRT and the stem cell also in the injection. And as Dr. Muzahim said, that the radio frequency is a very effective tool in the treatment of sacroiliac dysfunction. And as usual, it recurs after about six months to 1 year, and this is due to the regeneration of the nerve endings which inject. Finally, I agree with you that the surgical treatment should be postponed, and there is no carryover for the surgical treatment at the beginning, and should be trying to inject one and twice and thrice and even 4 times a year, and this is literaturally based, and also radio frequency. Lastly, for the surgical treatment, there is a mini open as you show us. But I have a comment. You show the iFuse system, and this system is not available in our countries. And the sacroiliac screw, as there is a big joint loading, there is some problems. I want to highlight that in Birmingham in 2018, Dr. Golang introduced a sacroiliac screw that it has a particular manufacturer with threads. As he proceeds the screw inside the joint, the screw taking a self grafting and to introduce it across the joint with subsequently increased the rate of union. Thank you so much, and thank you all.
Thank you very much. Thank you for those valuable comments.
We had one comment from our dear friend Dr. Atiq. He want to highlight the role of physiotherapy and strengthening the back muscles and the pelvic girdle muscles after fusion to improve the sacroiliac joint pain. Totally agree. I think all of us totally agree. One of our colleagues, Dr. Haider, want to highlight the role of EMG and nerve conduction study in diagnosis of piriformis syndrome. Yeah, totally agree with him. And Dr. Muhammad Negma from Egypt, he would like to ask about how to differentiate between pure sacroiliac joint pathologies that can be present to you as a radicular pain and true sciatica or double crush, sacroiliac and sciatica. I think local injection can differentiate. Yeah, it will ameliorate absolutely the pathology if it is double crush. If it is a unipathology, you will diagnose it clinically.
Actually, I like this, but I'll tell you, usually...
I think, Dr.
Further.
Okay, Walid, go ahead.
Yeah, I just want to say, always I tell the patient there is possibility of 2 pathologies. I would like to, because most of the patients, they will not that smart to differentiate between all type of pain. I'll tell them we'll go for the easy part, which is the injection. It will alleviate some of the pain, but not full pain. So you'll know which was which and which you can live with and which one is the one need real management. So I like always to start, sometimes if there is 2 pathology possible, with the easiest way rather than impact on surgical management of the spine pathology, because pain will persist and he will tell you that, oh, I did not get any benefit. So this is a way just for him to understand his pathology, and again you to further confirm your diagnosis.
Okay, Dr. Walid, I know you have to go to pray because the Isha is near. Thank you very much for your elaborative discussion. I'm sorry we cannot accept any more questions. We have 2 more questions from Dr. Sameh and Dr. Badr. Unfortunately, we cannot answer that. Please keep with us. Next week, we have with Dr. Atiq Zaman about spinal tuberculosis, and hopefully it will be a very excellent lecture as same like now. And we have another lecture, actually, most likely on Tuesday. It will be about transforaminal endoscopic surgery. This will be with Dr. Mohammed Al-Sous. This will be transforaminal endoscopic lumbar discectomy, one approach to most disc herniations. We will let you know as soon as we know. طبعا اخواننا في مصر in Egypt, they have their own schedule. Dr. Mohammed will talk to us about that. Dr. Walid, you can go if you like, but thank you very much again.
Sure. Thank you very much. God bless you. Thank you for inviting me.
Thank you,
really
Walid.
nice discussion. It was really nice discussion. Thank you, Bro Mohammed. Thank you all. God bless you all.
Thank you, Walid. Assalamu alaikum jami'an. Yes, it is really very encouraging to join a team from Dr. Saad Hamdan, Dr. Walid Awad, Dr. Sameh Abou Al-Futuh, Dr. Atiq Zaman, Dr. Ghazwan Skaf, Dr. Ghazwan from Iraq. Big team. They are trying to decrease the stresses on spine surgeons and spread and exchange the knowledge, which is fantastic. And to have on Tuesday, it is a social event. I can share the link with you. It is a social event. I mean by that, we will have a lecture about stress management will be delivered by Professor Yusr Al-Hawari, and another lecture will be about the history of pandemic that affect the Arabian countries and this world, the historical point of view, and what we learned from the previous pandemics. It will be delivered by Professor Osama Shazli, my friend and colleague from Ain Shams University. And on Friday, we will have at 3 p.m. another activity. It will be minimally invasive spine surgery meeting. It will be organized by my dear friend, Dr. Hatem Hamdi from Armenia. We have 3 distinguished speakers. One from Thailand will give us talk about